Hi there, and welcome. My name is Jeff Bell, and on behalf of McLean Hospital, I'd like to thank you for joining us for yet another episode of our educational webinar series. Today, we're going to focus on not one, but two mental health conditions: borderline personality disorder and post-traumatic stress disorder. While BPD and PTSD are two very distinct mental health conditions, each marked by specific diagnostic criteria and treatment approaches, their symptoms often overlap, and it's not uncommon for someone to struggle with both challenges. So we thought we'd take some time today to provide an overview of both BPD and PTSD and share some tips for spotting their signs and exploring treatment options. We also know that you have lots of questions, so we have brought in an expert to answer them. Dr. Gillian Galen is a senior child and adolescent psychologist specializing in dialectical behavior therapy, or DBT. She is director of training for McLean's array of programs for teens that use DBT to target self-endangering behaviors and symptoms of borderline personality disorder. Jillian, thanks so much for making time for us today.
Thanks for having me.
Well, we have a lot of ground to cover, and before we get to some of the overlap between BPD and PTSD, I think it might make sense to review some of the basic elements of each conditions. Let's start with BPD. Can you give us a working definition?
Sure. So borderline personality disorder falls in the sort of the category of personality disorders, right? So diagnostically, we're looking for pervasive patterns of different types of behaviors and experiences. Often these symptoms start in mid to late adolescence, through, and then they carry on through adulthood. Um, you're looking, so borderline personality disorder is an interesting diagnosis because in a lot of ways it's very non-specific. So you only need 5 of 9 criteria, right? So you're looking at like potentially around like 240 plus permutations of this diagnosis. Now, that is the math. There are sort of commonalities, right? Some of those 9 we see almost with everybody diagnosed with borderline personality disorder, but there's a lot of variety. There have been many efforts to try to make it more specific, and the field just keeps landing where they land. I do think it'll probably be an evolving, it's going to get more specific, I think. There's lots of controversy about the name. People
Mm.
don't love the name borderline personality disorder. So, I wouldn't be surprised in the future if sort of the name changed and it got a little bit more specific. But really what you're looking for is, these nine diagnostic criteria. So you're looking for like chronic emotion dysregulation. Okay, so lots of emotional reactivity, lability, instability, lots of movements of the emotion, not cyclical like bipolar disorder, but really reactive. So, and these are often moods that are prompted by something interpersonal, right? An exchange that happens interpersonally, or something intrapersonal, sort of thinking about sort of sense of self that tends to prompt these sort of emotional waves. You're looking for sort of as a result of that, unstable relationships, very intense, with, deep connection, then pulling away. You're looking for intense fears of abandonment, right? And they're real or perceived in borderline personality disorder. So it may be that they've had real abandonment, but there's an extreme fear of people leaving for many people with borderline personality disorder. We often see a lot of recurrent self-injury and suicidal behaviors as a way to manage emotion regulate, so that becomes a primary tool for managing emotions, as well as impulsive behaviors. So these kinds of behaviors are used as a skill, unfortunately, to regulate emotion because there's a real skills deficit in more effective long-term ways to regulate. Um, we're often seeing difficulties with anger. So either we see difficulty managing anger and you see a lot of anger, or you see no anger at all, like zero expression of anger. So it can kind of go on either end of the spectrum. You're looking for difficulties with sense of self, right? Sort of a difficulty having a true sense of who I am. Sort of, I often will say it's like people's like feet on the planted on the ground about who they are as a person, and instead you can see more of a taking on of different um, sort of senses of self, so almost like a chameleon. So people will say, well, when I'm with this group, I sort of dress this way and I act this way, but if I go with another group, I really act more that way. So it's a loss of feeling of who I am and more of a sort of a shape shifting sometimes as a way to connect with people. We often see chronic feelings of emptiness, which is actually very unique to borderline personality disorder. There really aren't other diagnoses in which people consistently sort of describe this sense of emptiness. There's also often a lot of self-hatred that comes along with that. And then there's this last criteria, which is it's described in the Diagnostic Statistical Manual as transient episodic psychotic episodes, which is sort of losses of reality, but it's in the context of emotion dysregulation. So it may look like somebody has sort of like disconnected and lost reality. However, if you pause when the intensity decreases, right? They again are much more grounded. So it's not like a psychotic disorder in the sense that people have a period of time of psychosis. These are brief, episodic periods of what can look like a disconnection from reality. So it's a
What do we
big
know about the
diagnosis.
it is a big diagnosis, and it sounds like dysregulations are really at the heart of this diagnosis for BPD.
Yeah, so in DBT, we kind of reorganized everything into just that, into these categories to think about the diagnosis in categories of dysregulation, right? So there's emotion dysregulation and everything that goes into that, right? You can put anger in there, right? There's interpersonal dysregulation. There's behavioral dysregulation. There's cognitive dysregulation, right, which is that sort of transient psychotic piece. And then there's dysregulation of sense of self. So it's a lot. If you look in the DSM, in DBT, we like to group them, and then you start to see how they all affect one another, right? So if I have emotion dysregulation, it's going to profoundly impact my relationships, right? And it's going to impact my behaviors and my sense of self. And so we often will look at them in a circle as how they can sort of interplay and like lead from one level to the next of dysregulation.
You mentioned DBT, dialectical behavior therapy. We will circle back and talk about that
Yeah.
as well, because obviously that's a big part of this equation. What do we know about the prevalence of DBT?
Yeah, so the prevalence of BPD it's probably around 2%. I think generally, um, generally what they'll say is the prevalence is, hang on, what's that? There we go. The prevalence is from I think like 1.5% all the way to almost 6%. But I think generally it's probably around 2 to 3%. It's more commonly diagnosed in women. But it often is equally occurring between women and men. If we're looking at sort of being just dividing it into sort of the dichotomy of men and women, which is where the statistics are with more of a gender diversity. I don't think we have as good a set of statistics yet. Unfortunately, what happens for men, many men that struggle with borderline personality disorder end up more in the detention and jails. They end up getting more of the behavioral dysregulation that lands them with those kinds of consequences. And the women tend to be more generally help seeking, end up more seeking treatment and in hospitals. But there's a real move to be identifying not just women with borderline personality disorder and having them have access to the number of different of treatment options that are there.
How about causes? What do we know about them? Do we know genetics, for example? To what degree genetics plays a role in this?
Yeah,
Environmental
yeah.
factors?
We don't know so much about genetics. From a dialectical behavioral therapy perspective, we look at the causation of it as an interplay between biological sensitivity and environmental invalidation. Okay, so that somebody is born biologically sensitive. They just come out that way. Lots of us are biologically sensitive in the field, meaning that we feel things longer and deeper than the average person. We have a higher reactivity and a slower return to baseline. So it takes us a little bit longer to kind of like let it go and move on, which again is There's nothing pathological about that. It's just somebody's biology. But when that collides with an environment that tells the exquisitely sensitive person that their emotions don't make sense, then from an early age, you develop these difficulties with emotion regulation and problems with sense of self. And those invalidating environments are a spectrum. It's so simply a mismatch, right? An emotionally sensitive kid with a set of parents that just aren't that wired, that emotionally sensitive, to all the way sort of abuse and neglect and trauma on the other end. So that's sort of the general feeling of what causes borderline personality disorder. There is certainly, if you have a mother or a father with borderline personality disorder, a first degree relative, you're at higher risk for developing borderline personality disorder, which, if you think about it, makes sense because you could both inherit some biological sensitivity. But often people that struggle with borderline personality disorder are going to, if they're not treated and learn skills, they're more likely to create inadvertently an invalidating environment, right? So most of the invalidating environments are well-meaning. It's just that we're not going the next step to recognize how exquisitely sensitive these kids are. So people that are biologically sensitive need a higher dose of validation than people that aren't.
I want to ask you about recognizing the disorder itself, and both at the clinical level and the layperson level. Let's start with the clinical level. How difficult of a diagnosis is BPD?
Um, so I'm someone that is like an expert in BPD. So for me, it's not very difficult. But I think in the field, it can be very difficult. There's a lot of stigma around BPD. And I think a lot of the stigma now comes from within the mental health field, right? So I will get people sent to me to diagnostic clarification, and they have borderline personality disorder. And their providers will say, well, they couldn't because they're nice and they're smart and they're caring and they're attractive. And so then what will happen often is that they'll get an array of diagnoses. So they'll come with a long, exhaustive list of diagnoses with a long list of medications to try to manage them. And their experience will be like the diagnoses kind of fit, but not really. Like they don't really. And so people are left kind of feeling like an anomaly, because people, in the field will avoid many times diagnosing this. And I can tell you, probably 85% of the time, when I've sat with somebody coming to me and I've gone over the diagnostic criteria, they've actually felt much better, right? Because they felt like, wow, okay, look, this is something, there's a name for what you have, and there's treatments for it. Like, as opposed to feeling like I don't fit into any categories, nobody understands me, I don't know what to do, which is a very helpless, painful place to be. So I think we need to get better at people diagnosing. There is a myth that you cannot diagnose borderline personality disorder before 18, which is not actually the case. You can diagnose it in, mid-adolescence. You need to be careful because you need to make sure that you're looking at what is normal developmental tasks of personality, for example, exploring different senses of who I am versus that like lack of sense of self that we find in BPD. But the beauty of diagnosing it early is that often the earlier you treat borderline personality disorder, the better the outcome. So why, if we know that somebody has it at 16, right, would we wait until they're 18? After many hospitalizations and hopelessness and pain and struggle, wait until they're 18 to actually give them the therapy that's going to work. And we know anyways that if you meet about 3 criteria of borderline personality disorder, you have a positive outcome to DBT, right? So we could head it off and really decrease a whole lot of suffering.
So, what about the average parent or educator or just loved one in terms of signs that they might look for recognizing BPD? Can you run through a few of those?
Sure, sure. So, I mean, I think, Self-injury is usually the first flag that people will look at. Just because you self-injure does not mean you have borderline personality disorder, but there's a very, very high likelihood that you need to start looking at some of those criteria for borderline personality disorder. So you're going to look for things like self-injury. You're going to look for things like chronic feelings of hopelessness or emptiness or loneliness. You're going to look for challenges in relationships. So very intense relationships, sort of off and on relationships that cause a lot of distress. And you're going to look for high emotion reactivity, right? So just a lot of emotional reactivity. Many people that I talk to, that I meet with that have borderline personality disorder, and it's very painful, but they all say, not all of them, but a group of them will say that many people gave them the message that they were like, their emotions were too much, like too big, and they were too big for them to manage, and they were too big for other people to manage. And certainly you want to keep an eye out when there's chronic suicidal ideation and chronic suicidal behaviors. But again, all of those things, that doesn't mean you have borderline personality disorder. It means you want to start thinking and really looking at this disorder, because certainly it could be a major depression, right? It could be other things too. But those are some of the flags that we start to look at, particularly in young people that may be developing the disorder.
So, Gillian, one of our goals, as you know, for this webinar series is to work in as many audience questions as we can. They've come with a lot of questions for you today.
Great.
And so this one's relevant to this portion of our conversation. Can anger, blaming others like parents, and refusing to take responsibility for actions be signs of BPD?
So it could. It could also be adolescent behavior. It could be signs of depression. So adolescent depression also looks very different than adult. I always say it looks different than the Cymbalta commercial, where everybody's really quiet. It tends to look more irritable. Just irritable, and blame can come in that. But certainly, I mean, I think, if there's a chronic, and again, we're looking for like patterns, enduring patterns of behavior. So certainly, if that's one behavior and you start to see some of these other behaviors come in, I think it's reasonable to say, yeah, there might be a real struggle with being able to sort of see behaviors and consequences, and then navigate the interpersonal skills, right? Because there's often, a skills deficit in those intense interpersonal relationships, that it could be there's some deficits in that area. So certainly something to keep an eye out. I would look around for some of those other symptoms as well.
Another question from a viewer: is there a spectrum of BPD?
Yeah, I mean, I think there's a spectrum of most illnesses, right? There's a spectrum of depression, for example, goes from dysthymia to major depressive disorder. There is the spectrum in terms of maybe levels of care, of the intensities of behavior. So in hospitals, right? So we see the most extreme, right? Cases of borderline personality disorder. Marsha Linehan, who created DBT, and many of the other evidence-based treatments for DBT are really designed for an outpatient basis, right? So an outpatient level of care. So many people with borderline personality disorder are in outpatient or not even in treatment at all. So there's absolutely a spectrum of symptom expression for sure.
You mentioned DBT several times, dialectical behavior therapy. Let's talk about that and other forms of treatment for BPD.
Sure. Right. So dialectical behavioral therapy is the gold standard treatment for right now, for extreme emotion dysregulation, suicide, and self-injury, which is, so that's sort of your gold standard. It's not easy to find in a lot of parts of the world. It can be an expensive treatment. It's a very effective treatment, but it's not the only one. Certainly, mentalization-based treatment has some really great outcomes for borderline personality disorder, as does GPM, which is general psychiatric management, which was developed here at McLean Hospital with John Gunderson and Lois Choi Kane. I think the thing that is really important to understand about borderline personality disorder is for many, many years, it was a diagnosis where there wasn't good treatment and people felt like you were just sort of stuck. Now it's considered a good prognosis diagnosis in the sense that there are multiple evidence-based treatments that people can access for care and that do quite well.
You mentioned levels of care in that oftentimes DBT is done on an outpatient basis. Can you talk about times where you might consider a partial program or even a residential program?
Sure. I think when you look at those like 9 criteria and things like suicidal behaviors, right, and self-injury are very, very active, right, and it's very, very hard to get the skill set and the ability to manage those behaviors, that those tend to push people into partial hospital programs, residential programs, where they're able to learn skills and get them at a higher dose than you could at, for example, a once or a twice a week treatment. And also if people feel just stuck, that the symptoms are getting in their way of moving forward. So you don't need to be suicidal or have struggles with self-injury, but that all those other symptoms are getting in your way of sort of building a life that often may drive people to a higher level of care because they're not moving forward in their general outpatient model of care.
A couple questions about treatment itself. A viewer would like to know how long on average is treatment for BPD likely to take?
So we often will say it's a marathon, not a sprint. Treatment can take years, but it's phased, right? So it's may sound sort of counterintuitive, but you can really help people decrease things like self-injury and even suicidal ideation, very acutely. So people can work and you can do work and treatment and within the first year, really make a big difference in there. Some of the other more entrenched patterns of interpersonal behaviors, sense of self, self-hatred, those do tend to take longer. And also we have to remember that, borderline personality disorder often comes with comorbidities, right? So that you may be having to treat other things along the way, but it is not, borderline personality disorder is not going to respond in the way that you would perhaps doing a CBT protocol for something like panic or a phobia, right? That you could sort of say, okay, in 10 to 15 sessions, we're going to be able to really change this. The DBT is going to take longer. Usually the first stage of DBT is at least a year.
Follow-up question to that. Does treatment for BPD become more difficult as a person gets older?
You know, I've done DBT with kids like as young as 13 and as adults as old as 65, I think, 65, 70. Harder it's an interesting, it gets different. Okay, so the brain of a younger brains have, laid down the tracks of those ineffective behaviors are not as deep. Right. So, behavior just works like behavior works. It's a lot of practice, right? So the more you practice an ineffective behavior, the better you get at ineffective behaviors. And, the more you practice effective behaviors, the better you get. So, some of this is, young brains are primed to learn. These are really treatments around skills and doing things differently, right? And thinking differently. So in some ways, younger brains are a little bit more malleable and their patterns are a little bit less entrenched than older brains. But this treatment was actually designed for adult women. This wasn't a treatment designed for young people. It was actually designed for adults. And that was where DBT started, and it's where MBT started, and it's where GPM started. So I think it's different. Changing patterns can be harder when patterns are more entrenched, but also people's ability to self-reflect can be more developed with their, they've got a better prefrontal cortex, right? And they've got better impulse control. So you can see there's different parts of these symptoms that can respond maybe easier or more difficult in a more difficult, be more difficult to respond to based on ages of the brain.
We're going to shift our attention to PTSD in just a moment here,
Sure.
but I do want to work in a couple more questions. We tend to have a lot of clinicians in our audience for this
Great.
webinar series, and I'm
Good.
going to assume that these next two came from clinicians. What are some screening tools or diagnostic tools to assist in diagnosing BPD? You touched on this earlier, but are there some specific
Yeah.
metrics that you
Yeah.
would want to share?
Yeah, I mean, I think probably the common one is, there's a Zan BPD that comes from Mary Zanarini here at McLean, which is a screening method. And there's also the SCID-5, which for clinicians, this is the structural clinical interview for the DSM-5, also does a really nice interview for borderline personality disorder.
Great. And then in addition to DBT, are there important complementary interventions that should happen simultaneously?
So typically when we do DBT is a stage-based treatment. So stage one is behavioral discontrol, where people are coming in with all of these active, really problematic behaviors, right? Self-injury, suicide, difficulty maintaining relationships, big emotion dysregulation that gets in the way of holding jobs and going to school and sort of living life. So in stage one DBT, we just do DBT and we get behavior in control. Once you move into a stage two treatment, you may add things like PTSD treatment or different or OCD treatment or different sort of protocols for more social pragmatics for people that may be on the autism spectrum. So first stage, we try to just get that behavior and those emotions under control by teaching skills. Then once those skills are developed, then we may do adjunctive treatments. Absolutely.
All right, we're going to come back to BPD. And of course, we're looking to talk about some of the crossover between BPD and PTSD. But let's lay out PTSD for folks as well in terms of how it works, how it's characterized, how it's treated, and so forth. The first question I want to ask you is the distinction between post-traumatic stress and PTSD.
Sure. So post-traumatic stress is like the stress that we have after a traumatic event, right? After witnessing something that is traumatic. From a diagnostic perspective, that's often called the period of acute stress, or if you want the diagnosis, acute stress disorder. And that's the first kind of 30 days. And that's a normal response to trauma, right? So if you or I had a traumatic experience, the expectation would be that we would have an acute stress response. So we would have physiological changes. We might have some intrusive thoughts and memories, right? We might have some dysregulation. We might have some nightmares. We might have some flashbacks. That's what happens. That's the body, the brain's normal experience, right? Now, for most of the time, right, with some emotional processing and validation and exposure, that remits within the first 30 days. And then we move on. We certainly have memories, we have feelings. If that does not remit, if that continues, then we get the diagnosis of post-traumatic stress disorder. Okay, but that acute stress is normal. That's like when people are traumatized, we're going to have those experiences. Most people, it doesn't convert, right? But in some cases, if those persist beyond 30 days, then we end up with post-traumatic stress disorder.
We often hear PTSD associated with the horrors of war, which of course it is. Is it too closely tied to that? In other words, does PTSD affect a much broader population than those directly impacted by combat?
Absolutely. I mean, absolutely. PTSD, I think, is about 6% of the population will have PTSD. And that's not all from combat trauma. Really, PTSD is about witnessing, right? Witnessing a traumatic event, right? That you're either directly seeing something where somebody that you either know or don't know is killed, is very, very hurt, is like helpless and like in danger. So people can get PTSD in car accidents, right? There's many like sort of day to day, house fires, Um, you just have to be witnessing a traumatic event and not, or there, in the DSM-5, they also added a PTSD component for people like first responders who are constantly and chronically, having to respond to emergencies in which somebody is gravely hurt, or has died. Right. But so you can think about there's lots of, unfortunately, opportunity. We hope that people stay within that acute stress time and get some support, and they don't end up converting to the full diagnosis of PTSD.
I have to toss out one more term for us to talk about before we move on. Complex PTSD. We hear about
Sure.
CPTSD. What is that getting at?
Yeah, so CPTSD, and there's a lot of controversy around CPTSD, which is it's the chronic, you're chronically exposed to trauma, okay, over a long sort of developmental period of time. So this is often what happens for young people that are experiencing any kind of abuse and trauma. Oh, so it's over time, it's years and years and years of this trauma, as opposed to sort of a PTSD where it's like a single episode trauma. Right. So complex PTSD, when we go into that diagnosis, actually has even more overlap with borderline personality disorder, because when you start at a young age and you're chronically exposed to trauma, that impacts, of course, your development of your sense of self, and certainly like the world and safety and relationships, depending on the kind of trauma that you've experienced, which mostly is going to be some sort of interpersonal trauma with complex PTSD.
Let's talk briefly about diagnostics for CPTSD and PTSD. What does that process look like, diagnosing either?
Yeah, so if BPD has this sort of like a non-specific experience, diagnostic experience, PTSD has a very, very specific set of diagnostic criteria and different categories. So different components in which you need certain combinations of symptoms that they have, right? So the first thing for PTSD is that you need an exposure to a trauma. Okay, so that is the first piece. The first piece, you need they have to have been exposed to a traumatic event, right? Either by directly experiencing it, like it happened to themselves, right? Witnessing it, watching it happen to somebody else, learning about something, learning in detail about something that happened to someone close to you, like a family member or a close friend, and then this new addition, which was the experiencing repeated extreme trauma, which is really tends to be our first responders, paramedics, police, firefighter, where they're just over and over exposed to very painful and traumatic details. So that's the first thing. You have to have an exposure, a trauma exposure for PTSD. Okay. Then we're going to go into all these categories of symptoms. So the first one is what we call intrusive symptoms. Like these are the ones that kind of they intrude in our minds. Like they come when we're not thinking. And you have to have one, at least one of this list of them, which is the memory of the trauma has to kind of intrude, and that like I'm doing something and then all of a sudden there it is. Like there is that memory, right? That it's coming up in my dreams. So maybe I'm having nightmares or distressing dreams about the trauma. I'm having flashbacks, right? It's like all of a sudden, sort of, and we call that part of dissociation. I dissociate and like I lose touch with where I am, and I'm almost like transported back into whatever that trauma was. That if there's things that represent the trauma, that I experience a lot of distress, like high levels of distress. And that I have like big physiological reactions to those cues. So those are the intrusive ones. Then I have to move, and I need at least one of those. So this is how it's so specific. We move into the next category, right, which is avoidance symptoms. Okay, and this is often what happens if we have an acute stress response and we do a lot of avoidance of the trauma. We don't talk about it. We don't get validation from other people. We don't get support. We stop going to the places or thinking about it. This is a huge risk for converting from acute stress to PTSD, right? And so if you have PTSD, you have to have persistent avoidance of things, right? Of the either the memories and the thoughts and the feelings, like I push those out, I'm not interested in those, or any kinds of external reminders. Like I don't go to certain places, I don't talk to certain people, I don't read certain books, I don't watch certain movies. So you have to have at least one, if not both. Many people have both sets of those avoidance symptoms where their life gets smaller and smaller and smaller as they try to survive and not be overwhelmed with the traumatic feelings by avoiding things. Okay. So there we've got, now we're on to the next set. Those were our avoidance symptoms. Then we have mood symptoms, right? So negative sort of mood and cognition, right? So you have to have at least two of these. And it's a lot to remember, right? So a lot of people will just it can be helpful to pull up the diagnosis and really kind of look, because I'm going through it quick and it's a lot to remember. But you have to have at least two of these. So there's 7 of them. There's inability to like remember the trauma. So big gaps, like big kind of gaps in your memory. Start beliefs about the world start to change, like the world is bad, I am bad, nobody can be trusted, nothing is safe, right? So we start to look at the world through a lens of lack of safety. We start to kind of blame ourselves or blame people that maybe aren't responsible for it. So we sort of get caught in like sort of moving into this like looking for blame, although it ends up being very distorted, right? In an effort to sort of find understanding, often for the not something that is understandable, like these accidents, like we cannot explain them, right? It would be easy if there was a single person to blame, but it's often more complicated than that. Just a persistent negative mood state. So just feeling, angry, guilty, shameful, sad most of the time. You get a little bit of an overlap with depression where you get a marked sort of a diminished interest in things that used to bring you joy. Like, I don't want to go to the gym anymore. I don't want to go to my book club. I don't want to hang out with people. I don't want to go out to restaurants anymore. Feelings of isolation and detachment, like really detaching from other people. And just a difficult time experiencing any kinds of positive emotion. So it feels almost impossible to feel joy. So you need to have 2 or more of those 7. Most people have more than 2, unfortunately, by the time they get to PTSD. Then we're on to the next category. So you can see how this is a very specific diagnosis,
Yeah,
right? So the next
definitely.
one is difficulties in like arousal or reactivity. So you need 2 or more, and then you're going to start to see a little bit of the overlap. So if you take out any causes, here you can start to see a little bit of the overlap with some of the BPD, right? Which is irritability and anger, like kind of difficulty managing your irritability and your anger. You can get some reckless behaviors, right? So often people that have been traumatized, people say like, you've already been traumatized once. Like, why would you do something so reckless, right? But you can see that as a symptom of PTSD. Hypervigilance, right? So that always being on the lookout. So people that are hypervigilant are always looking for the exit, looking for something that is dangerous, potentially in every kind of situation. It's exhausting to be very hypervigilant. An exaggerated startle response, right? This is very, very common, so the phone will ring and somebody will jump, right? Or there'll just be a noise outside and you'll see somebody, jump. It's a loud noise, but they'll startle, right? And that's that physiological activation. Difficulty concentrating. Like, so often people say, I used to read books, I used to watch shows. I can't do that anymore. I can't sustain my attention, often because there's a lot of intrusion, right, from those other symptoms that we talked about. And then poor sleep, right? And again, you can see how they link. If you get nightmares, it's very hard to get good sleep anyways. And then again, we look at the duration, right? So it has to have lasted more than a month, right? So you would convert from acute stress. And all of this, then the final thing, which it's hard to imagine that it wouldn't be, but this has to be a level of distress that impairs you from being able to live your life. So you can see
A
we
lot of
very, very specific diagnosis
very.
with very, very clear diagnostic criteria. Is quite different than borderline personality disorder.
I want to bring this all together with BPD. Very quickly, if you would, though, first, talk to us about treatment for PTSD.
Yeah, so there's a lot of great treatment for PTSD. It's challenging treatment, but there's really great treatment. Um, there is prolonged exposure was like the first real big treatment for PTSD that was really done in the VAs. Like that's what they were originally doing a lot of treatment. So there's prolonged exposure. Um, there is there's now cognitive processing, which is called CPT. And that is also for PTSD, and that takes a more cognitive lens as opposed to an exposure lens. There's trauma-focused cognitive behavioral therapy, right? There's EMDR, which is the rapid eye movement therapy. In DBT, we actually, because people with borderline personality disorder who also have PTSD are often excluded from a lot of these treatments because of their self-injury and their suicidal behavior. Within DBT, we have something called DBT-PE, where they have taken the prolonged exposure that was the gold standard for treating PTSD, and they've integrated it into a DBT model. So there's actually wonderful, really, really successful trauma treatments. I think there's a new narrative therapy, a writing therapy. I think it's like a 5-session writing a narrative therapy for PTSD. So there's really, and it's wonderful treatment options. Then they're challenging.
All right, let's bring all this together. We've been talking about the overlap between BPD and PTSD. First of all, how often does that happen? What does co-occurrence look like in terms of prevalence?
Yeah, so I mean, I think they'll say somewhere between 40 and 60% of people with borderline personality disorder have had trauma. So
Okay.
it's a pretty wide range. Probably around 50 have had some sort of trauma.
To what degree does the co-occurrence complicate diagnostics, for example?
Yeah, so I think if you're pretty familiar with the two diagnoses, it isn't quite as complicated. But really, the key to so complex PTSD and BPD can be hard to tease apart. They can be very hard to tease apart because on top of the trauma, right, they also struggle with chronic feelings of often guilt and shame and hopelessness, difficulty with emotion regulation, difficulty forming relationships. But again, when you're trying to diagnose these and pull them apart, you need to look at the etiology of these problems, right? So PTSD is coming from an exposure to a trauma, right? That there's been a single episode trauma, right? Or if you want to have your flag up for CPTSD, there's been chronic, enduring, repeated trauma, right, over time. Okay. So if you look at a lot of those overlapping symptoms, like you really have to look at like what's the cause of them, right? So is the problems with emotion dysregulation that happen in BPD, those are happening regulating emotions everywhere, right? It's a long-standing problem regulating emotions in all contexts of their life, right? When you look at the emotion regulation problems that happen in PTSD, often even in complex PTSD, you have to go back and look. The problems are because they're having difficulty regulating emotions about the trauma, right? So when the trauma intrudes, when they have the nightmare, when they think about the trauma, you see the poor emotion regulation, right? Whereas with BPD, it's across the board, right? So you're seeing difficulty regulating emotions in a lot of different contexts. So you really need to look at like what's the cause of these different symptoms, right? So suicidal behavior and self-injury in borderline personality disorder is a way in which people are coping with that chronic emotion dysregulation. If you were to see that behavior in someone with PTSD, you would be able to link it. So the prompting event would be related to their trauma, right? It wouldn't be related to getting difficult feedback at work or a loss of a relationship or a poor grade in school, right? It would go right back into the traumatic event. Same thing with hypervigilance, right? Hypervigilance can be related to that trauma. Sometimes you see hypervigilance in borderline personality disorder, but it's often in the context of what we call interpersonal hypersensitivity, right? That there's a lot of worry about how people think about me and how people going to leave me, right? Versus hypervigilance because I have safety, because I've seen something bad happen and I've been exposed to a trauma and I'm afraid it's going to happen again.
Here's a question about specific causality. Can PTSD trigger symptoms of BPD? Does it work that way?
Possibly. I mean, I think maybe in the right context, but I think probably a single episode trauma that somebody is going to have that has PTSD is not going to lead to ultimately a diagnosis of borderline personality disorder. Now, complex PTSD, right, can, because that's recurrent abuse over time is by definition an invalidating environment, right? So if you're biologically sensitive and you're exposed to that, that's where you start to see a lot of overlap between the symptoms that come out of borderline personality disorder and the symptoms that come out from complex PTSD. I haven't seen too many people say that PTSD causes the BPD. However, certainly people that have borderline personality disorder, there may be people that could be at higher risk for getting PTSD because some of the risky behaviors they engage in simply put them in a place in which they could be more likely to be traumatized.
So let's say somebody has, in fact, been diagnosed correctly with both BPD and PTSD. What does that mean for treatment? How does that complicate things? To what degree does a clinician need to tease out what's what in the treatment protocol?
Yeah, so it complicates things depending on the symptoms of BPD that you have. So if you have symptoms that include self-injury and suicidal ideation, then you're going to have less access to a lot of the going right into a trauma treatment, right? Because many of those trauma clinicians are amazing, but they're not quite skilled at managing the level of emotion regulation that could, someone could then say, I don't have the skills to manage that. I'm going to self-injure. Right. So when you have the two of them together, sometimes what you have to do is you have to provide skills to decrease the intensity of suicide and self-injury, decrease the reliance of self-injury as a way to cope, increase a skill set to manage distress and dissociation, and then you can move into the trauma treatment. This is why Melanie Harned created DBT-PE, because what was happening is people that were coming with both borderline personality disorder and PTSD were being given the message that in order to receive PTSD treatment, they needed to have 1 year free of self-injury and suicidal behaviors. But the trauma was driving a lot of the emotions that were making it very difficult to only sort of manage, so people could kind of use the skills and hold on for dear life, but not for long enough. And then they were getting stuck suffering. So what she did is she requires in those protocols that we do that you need basically 4 to 8 weeks free. So if we can get skills on board, good. If we can get your skills on board and you can manage them, manage intense emotions and urges and your dissociation, and it's your first, then you want to do this treatment. If you can go 8 weeks, 4 to 8 weeks, we will then give you the prolonged exposure, which has been modified to include DBT in it, so that then people are not having to wait a year, which is impossible. It's too hard. You can't wait a year if you've got PTSD symptoms that are just becoming too hard to manage.
As you've mentioned, you specialize in this particular area, specifically with BPD. What is your guidance for a general practitioner in clinical psychology? At what point might they want to refer out? How can they get themselves fully up to speed on the complexities of these topics and so forth?
Yeah, I think for everybody, all providers, we need to know like our expertise and our limitations. So I think, if you've got someone with BPD, you've got somebody with PTSD, you need to assess whether you can treat that. Are you skilled to treat those kinds of things? And if you're, and can you get some guidance, some support, and some supervision? right? And if you're not, it's time to refer out, right? And I think, there's, lots of, you can go and Google and see who in your area, does DBT. Is DBT accessible to the client that you're working with? What are the PTSD, the PTSD treatment options maybe in your area? Now there's a lot of Zoom that's happening. So I think the best thing to do is tease it out diagnostically by using your diagnostic skills. If you're not sure, get consultation, right? And then really decide, like, what is my ability to treat this? Because it's painful when someone is suffering and you don't have the skill set to be able to treat them.
I want to circle back to something you said earlier, Gillian, because I think it's an important topic, and that's the stigma around these labels, PTSD and BPD. You suggested at one point that clinicians themselves might have some issues in terms of using those labels. Talk a little bit more about that and what you'd like to see done in terms of the conversation around this.
Yeah, I mean, I think that it stems within the mental health community, and then it blossoms outwards, right? So, I mean, there are some really awful things online about people with borderline personality disorder. Really, really, really terrible things. And yes, certainly those may not be driven, they may be driven by people that have experienced how painful it is to be in a relationship with someone with BPD, right? Or that they've had a parent or a family member, and we have a forum for people to speak their mind about this. But I think the problem really does, in terms of treatment, come from within our community, because if we're not correctly diagnosing people, right, and often people will get misdiagnosed as bipolar disorder, they will get put on a lot of very, very heavy medications that both don't work that well, and cause a lot of side effects, and don't work, they don't help them. And they don't get the treatment when, as we've talked about, there's a lot of treatment options out there. There really is. So I think as a field, we need to get more knowledgeable about borderline personality disorder, more confident in being able to diagnose it, and then supporting, treatment. We need to get this, to primary care doctors. We may need to make treatment accessible. But this is a wonderful thing about GPM, right? That really simplified how to help practitioners without a lot of training effectively treat people with borderline personality disorder, see these things as behaviors. Borderline personality disorder can be challenging because people have very strong feelings about it, right? They have very strong feelings about the behaviors that are ineffective that people use.
Let me squeeze in a couple more audience questions. We've had a number of questions come in about whether or not BPD ever goes away. Is it chronic?
So it's really interesting. So Mary Zanarini has done a longitudinal study. She's here at McLean. And actually, BPD improves over time with no intervention, right? With the development of your prefrontal cortices, you do see, with no intervention, a decrease in things like self-injury and suicide. However, it doesn't if it's not treated over time, most people aren't able to hold jobs because of the mood dysregulation and the interpersonal challenges. They have a lot of loneliness. They have a lot of side effects if they've been medicated. They don't have what we would call a life worth living. But if so you could say with no intervention, it does get better over time in some areas. So self-injury tends to go down, suicidal behaviors tend to go down. You get good development in your prefrontal cortex. So some of that reactivity goes down, but it doesn't go away to the point where people will report living like a fulfilling life.
A question about complex or CPTSD. Can it come on from long-term medical issues in childhood like diabetes or years of surgery and invasive treatment?
Sure. Yeah. I mean, I think a lot of people will have PTSD from medical trauma. It certainly depends, like what that medical trauma was. And again, what's so interesting about PTSD is that not everybody gets PTSD, right? There are people that are exposed to the same traumatic events, and some people get PTSD and some people don't. So certainly there are people that have PTSD from medical trauma, either in childhood, like chronic illness with many medical interventions, or even in adulthood.
One more question, a little broader than our conversation today. Can you talk about dissociation or derealization in people with BPD?
Sure. So dissociation often happens. That's that cognitive dysregulation, and dissociation often happens when emotion dysregulation is very, very high. So I've often had people say it's like a flashpoint. Like I get so dysregulated, and then I dissociate, right? I sort of lose touch. So people will describe things like, things look kind of like dreamlike, or I don't feel like I'm real. So people will like touch their arms to see if they're real. People will sometimes see depersonal, they'll like feel like I'm up in the corner of the room, kind of like watching. And this is all a symptom of extreme, extreme emotion dysregulation. And what you'll see is that when emotions come down, and they begin to regulate, then the clarity comes back, right? So again, we teach skills around how to manage dissociation because it's very, very life interfering.
I want to
Real.
wrap up with any specific tips you have for loved ones, somebody supporting somebody dealing with either BPD or PTSD. This can be scary, and I know that all the information we're providing today can be a little overwhelming for some loved ones as well. Bring it back to the basics here. What would you want them to know to start off this journey with a loved one with all these
Yeah.
challenges?
Yeah. I mean, it's, first get support yourself. I think it's very, very hard to see someone you care about suffer and struggle. So get support would be my first piece, and be curious. Be as curious as you can about what their experience is. I think for some loved ones, it can be very challenging because people aren't ready for treatment all of the time. And then we have to sit with them when they struggle. But, be curious, ask if people need help, help them find resources. Really, really try to support them. For borderline personality disorder, the National Education Alliance for Borderline Personality Disorder offers support for families. Watch webinars, learn things, read things, and mostly get some support and guidance for yourself because we use the oxygen mask on the airplane. If you go down and you don't put that oxygen mask on, you're of no help to the person next to you.
Always a great reminder. You mentioned resources. Are there any other resources that you want to put out there, particular books that you find helpful on these topics, for example?
Um, shameless self-promotion if you want to know about DBT.
Please.
I've written DBT for Dummies and the DBT for Dummies workbook. If you have an adolescent with borderline personality disorder, Blaise Aguirre wrote a great book called Borderline Personality Disorder in Adolescence, which is great. For PTSD, I think kind of the most well-known helpful book is called Trauma and Recovery. It's a very dense book, but it provides a lot of really sort of foundational information and support to better understand PTSD.
Wow. Gillian, this hour has flown by. You have done a terrific job helping us understand some very complex topics. Thank you so much for all your time today and your commitment to helping others. We appreciate it.
Thank you so much for having me. It was great to be here.
Again, that is Dr. Gillian Galen. And to those of you watching, thank you for your interest in our educational webinar series. We hope you'll come back for future sessions, and we wish you a wonderful day.